Hello.
Hey, David.
Yeah.
Hi.
Okay.
So we're online now, I guess.
Yeah.
Hello, everyone. This is David Hagin. Thank you very much for joining us today for the CIS conference webinar series. This conference webinar series is supported both by USAID.net and LACID. And we have two, I hope, at least one very interesting case. The first one case will be presented by me. It's a case of an IBD-like presentation in a 26-year-old male, and the senior mentor with me today will be Dr. Sergio Rosenzweig from the NIH. And the interesting case will be actually the second case, a case of idiopathic thrombocytopenia with family history of SLE. Will be presented by Elena Hsieh from Colorado and senior mentor Dr. Mike Jordan from Cincinnati Children's Hospital. So I think we can start with the first presentation. So I would like to present a case of IBD disease. And our case started actually with a 26-year-old male who was admitted with a long history of abdominal pain and assumed to have some form of IBD-like disease. And he was admitted due to severe abdominal pain, vomiting, and weight loss. But it wasn't a real last admission. Actually, it was transferred from another center where he already underwent some studies, and we knew that he had imaging studies that suggested possible pancolitis, and also had upper endoscopy a couple of months before prior to his current admission, which showed candida esophagitis. And the concept was regarding an IBD-like or a Crohn-like disease, whether there is something that we can do to investigate this case. But when we spoke with the patient, actually with his mother, then she described a long history of symptoms. And he started suffering from diarrhea at the age of 4 months of age, so very early onset, assumed to be due to milk allergy, and actually it proved once milk was taken out of his diet. But then later on in life, he started to develop a recurrent aphthous stomatitis since the age of 3. At the age of 13, he developed rectal bleeding, underwent sigmoidoscopy, which was normal, and that was assumed to be secondary to anal fissure. At the age of 16, he developed difficulty swallowing with painful swallowing, and upper endoscopy showed multiple ulcers. He had normal colonoscopy at the time. And since then, he underwent repeated endoscopy every couple of years, and they all showed similar things, so mostly ulcers, and that's about that. Because pathology and the evaluation wasn't very typical, he was assumed to have some form of IBD-like disease. He didn't receive any treatment for that. About 10 years later, at the age of 23, there was some change in his clinical presentation, more severe symptoms, more severe pain. Upper endoscopy again shows the same erosive gastritis. This time colonoscopy showed mild terminal ileitis. He also undergoes video capsule endoscopy with lymphoid hyperplasia in the terminal ileum, and biopsies actually show the same thing. So in the esophagus, he has esophagitis, and in the colonoscopy biopsy, there is some lymphoid aggregation and lymphoid hyperplasia. He has normal MRE, and ASCA shows strong positivity, more IgG than IgA. And at that point, he started on steroid treatment. At the age of 24, again, recurrence of his symptoms, but this time, in addition to the ulcers, there also esophageal candidiasis, and he received treatment with fluconazole with good improvement. And a year later, second flare-up, again showing esophageal candidiasis. So it's not the second flare-up, but the second time that esophageal candidiasis is demonstrated. And if we think about his history of infection and other symptoms, so it's not only the ulcers, he suffers from recurrent oral thrush, and that was most prominent between the age of 3 to the age of 13. His mother reports that he lost a lot of school days, mostly for short episodes of fevers, mostly self-limited, so he would miss a day or two and go back to school, but wasn't really sick other than that. And the other thing that I described before. He has some fungal infection on his skin, but that improved with the fluconazole treatment. and had some psychiatric problems and was diagnosed with major depressive disorder, but that was diagnosed only later in life, and I don't know if that's the result of his chronic illness as well. If we think about the family history, so family history is not very impressive. We have the patient on the left. He has one sibling, one brother with seronegative spondyloarthropathy, but no other symptoms. And that's about it. There is another remote relative from his mother's side with ulcerative colitis. So back to his current admission, the patient was again admitted for worsening abdominal pain, difficulty swallowing, recurrent vomiting. Based on his previous episodes and the notion that he might have some fungal infection also, so he was treated immediately with antibiotics, fluconazole, and systemic steroids. And he slowly improved with treatment, but by the time that he got repeated upper and lower endoscopy studies, it was all normal. So there was no evidence for ulcers. The pancolitis that was suspected based on previous CAT scan of his abdomen wasn't there, and there was no evidence for fungal infection whatsoever. So we went over his lab work. Most of that was done before he was admitted, and I have to say that the lab work was generally normal. So he had negative stool cultures. CBC showed only mild thrombocytopenia. He had normal chemistry, negative HIV, and ASCA was done before, but it was already positive. He had the IgG of 83, which is above 35, considered strongly positive. IgA was mildly elevated. And if I think about it, the thing that we completed was, again, repeating his immune workup. So he had normal lymphocyte subsets with absolute CD3 of 1295, normal CD4, CD8, CD20, and CD56. And the antibody levels were also normal, and that was done several times in the past. So it's not only a single IgG measurement. We have it over the years several times, and it was almost always normal. We completed his FOXP3 staining, and compared to control, the patient and his brother had mildly elevated percent of regulatory T cells. But something that seemed to be a bit unusual is this. So in the upper row, you can see staining for FOXP3 and Helios. Healthy control is on the left, and the upper right quadrant shows the Treg population, which percent-wise seem to be normal or increased in the patient and his brother. That's the middle column and the right column compared to the control. But if you look at the upper right quadrant of the patient Tregs, maybe you can see that the FOXP3 is mildly reduced compared to the others. And in the lower panels, this is staining for FOXP3 and CD25. And here we can see, I think that the CD25 high population is actually missing. So maybe we can stop here and see if anyone has questions or thoughts about the case.
Any questions from the audience? I think I'm currently looking at the chat panel, and I don't see any comments unless I'm missing. I think I'm looking at the right place.
Yeah, I think so too. I don't see anything either.
There's somebody.
That's what I'm thinking. That's good.
Okay.
Do we? Okay.
Okay.
Want
So
to?
I can continue. Does anyone have any other questions?
So David,
okay, so,
I do have a question for you. So what was your working hypothesis? So what was your idea? What was your differential? What was you thinking about?
So actually, I had a long talk with the mother, and the mother is a physician by herself, so she's a general practitioner. And for me, it was a bit surprising to see how she handled the case over the years, because he was evaluated very thoroughly, and they went to one GI person after the other looking for an explanation every time. And when I heard the story, the only thing I heard all the time was GI and fungal infection, GI and fungal infection. That's all what I was hearing, and I in my head, I thought, yeah, I know what I need to look for. So it seemed to be pretty obvious at that point. And yes.
I guess I had a question about looking at the slow plots. When we look at the patient, I mean, I think in the SIB, you can see the abnormality is clear. If the patient does not look like he has very many cells.
Yeah, that's
so I think it's harder for me to sort of make an assessment of the percentages, you know?
I think so too.
So was the SIB basically characteristically almost same severity as brother? Because I think your description was a little different.
So the SIB, the only thing that he has is seronegative spondyloarthropathy. No other issues. He doesn't have any GI symptoms at all.
Right.
So I think there is a missing population maybe of the CD25 high. There's that more Tregs cells. But yeah, I agree that there are not as much events in the panel compared to the other two. But percent-wise, I think it looks okay. But again, the MFI might be a bit low.
There's a question about that.
No, we didn't do that.
It seems to be a bit strange that the IBD usually is associated with decreased Tregs, but I think your result was that it was increased potentially, I think is what you said.
I think percent-wise, it looks a bit higher compared to the control. But I think if I want to address let's call it the quality of the Tregs, I think this is not the typical population that I would like to see.
Did you do a DHR? That's another question.
No, I didn't do the DHR, and I don't have the stimulation test as well. I do have CH50, which for some reason was tested before. I didn't order that. I mean, it's always good to check that with in general, but these two, I don't have these two things.
And how about TH17? That's another question.
Also, no, I need to complete that. We'll do that. But I think that was our line of thought as well. So if we have CMC, if we want to call it, we can call it chronic mucocutaneous candidiasis, because that's one of the things that were there the whole years. Even the GI symptoms were the more prominent symptom. He did have the oral thrush over the years, and there was some fungal infection on the skin, and recent endoscopy studies showed there's esophageal candidiasis. So yeah, we were in that line of thought.
There's a suggestion that in the sibling with the symptoms of arthritis, you could potentially think about not too associated diseases.
Yeah, I think that was a good thought, especially with the involvement of the terminal ileus. So I guess also that's a good question. I think that the fungal infection were explained. That's one of the reasons that there was some delay in involving us, because they assumed that the fungal infection was the result of the steroid treatment, even though when he had the oral thrush over the years, he wasn't receiving any treatment. So they were there for many years, but the more invasive, it's not invasive, but the involvement of the esophagus was only displayed later on.
So there's a question of phospho-STAT1, which may be a good prompting to maybe continue to the next slide.
So I think also the way I presented it when I was speaking to the family and the patient and his mother, all I heard was again CMC and GI, and so we indeed the next step was to do the STAT1 phosphorylation. So if we have here a normal control, the upper panel shows phosphostat1 in unstimulated patient, IL-27 in the middle one, and interferon alpha in the lower one. Then if we add the patient result, you can see that there is definitely an increased phosphorylation of STAT1. So our working hypothesis at that point was that the patient has STAT1 phosphorylation, STAT1 gain of function mutation, and I don't think we had a lot of. I mean, it was pretty clear that that's what we're dealing with. And following that, yes,
David,
sorry.
One question. So go back to your STAT1 phosphorylation. I said, for any reason, did you test interferon gamma also?
No, I don't test usually. I need to add that to my panel. And I think usually it's. I think the shift is less clear if you check it on lymphocyte. I know that you have different results. Maybe you need to get on the monocyte instead.
Yeah, 100%.
But I think that's 20-minute stimulation. It's easy to perform. So that's my first assay. Maybe you should add data from there's an increase. I'm sorry?
My curiosity, do you ever look at time points? So this, I'm assuming, is one time point. Do you ever sort of look at several time points
No,
to see that
usually,
the STAT1 stays up?
so we used to, way I used to do it before was to do 3 time points, also to see the increased phosphorylation and delayed dephosphorylation. You know that there are different defects that behave differently. So some of them, there is also a delay in dephosphorylation. Some of them just show increased phosphorylation in the beginning, and that's it. But that actually was the first essay that I did in my new lab. So I was happy to see that, and that was a good start. But yeah, I need to add the other time points and show also the kinetics of the dephosphorylation.
And what cells are you looking at in this assay, David?
These are CD4s. I'm sorry for I didn't mention that, but these are CD4s.
And David, just out of curiosity, do you check also the total levels of STAT1? You know that there are people that they believe that the biggest problem with those patients is just that they have too much STAT1. So did you check also STAT1, not phospho-STAT1?
Just by Western?
No, just by flow.
Yeah, no, I did not. Maybe I should.
You should ask Offer. Do you know Offer? Offer
yeah,
Zimmerman?
Sure, Offer.
Yeah, contact Offer.
You know,
He will convince you.
Okay, should do that. And we should mention Offer again. So I think if once we had the STAT1 in mind, I think the reasonable next step is to, assuming that the patient is severe enough, is to consider JAK1/2 inhibitors, and that based on this report and other reports showing that you can actually reverse the hyperphosphorylation and reduce the or improve the balance between different pathways. And what was shown in that paper, that actually in the right upper side, you can see that treatment corrected the hyperphosphorylation induced by different cytokines. Here I think it's interferon gamma, and also restored the level of the IL-17 positive cells. Now, if we mention Offer, then Offer just published another paper showing that JAK1/2 inhibitor treatment caused invasive, or at least showed a complication of invasive fungal infection. So before asking the insurance company to approve that treatment, we want to make sure that the patient will actually have a STAT1 mutation. And we ordered some genetic testing, and what we expected was actually found. So the patient had STAT1 mutation, position 437, and that's actually a novel mutation. It wasn't described before, but if you can see the slide, most of the mutation are actually in 2 domains: the coil domain and the DNA binding domain, and this mutation is also located in the DNA binding domain. So I think what we have is a pretty supporting clinical story. We have supporting flow data and confirming genetics, so everything is okay. And the small twist that we have here, that when I saw the order sheet, actually there are 2 options. There was an option for single gene sequencing, and what I should have done is just write the name STAT1 next to the gene name and pay the 250 euros. But there is a second option of ordering a full panel of 70-something genes for the same price. The only difference is that it's going to take 8 weeks instead of 4 weeks. And actually I couldn't help myself, and we thought, hey, this patient is sick for 26 years, another 4 weeks won't make a difference. So we ordered the full panel. And what we found, is the same STAT1 mutation, but there is another mutation in NF-kappa B1. It's an arginine to glycine, position 335. So when I saw the report, the mean allele frequency was not available, assuming that it was a new mutation. And I thought it was a quite significant amino acid substitution, which was located in a critical region right next to, between 2 serines that need to be phosphorylated for activation of the NF-kappa B1. But Sergio actually showed me otherwise, and the allele frequency is actually 0.4%, which is still lower than 0.5%, and depends on how you set your threshold, and especially in the Ashkenazi Jewish population, and this patient was half Ashkenazi Jewish. If we think about, if we want to estimate how pathogenic the mutation is, or at least based on prediction software, this amino acid substitution can be either passively damaging or severely damaging the protein function. And when I saw this result, I was again kind of concerned that JAK1 inhibitor in this case, when there is another mutation that might cause some form of indeficiency, maybe JAK1 inhibitor will complicate the situation. And the thing that we are now considering is whether or not we need to treat him, or we can treat him with JAK1, assuming that he will be symptomatic or more symptomatic. And the other thing that we're wondering about this NF-κB1 mutation is whether or not it can explain the seronegative spondyloarthropathy of his brother, because in the several cases, at least that or families that were described by Miko's group, at least several of them had mostly seronegative spondyloarthropathy or monoarthritis, and he fits that description. So I think if you have any question, I'll be glad to try and answer them.
Question comes with any info of 2-copy versus homozygous for either mutation?
I think both mutation are homozygous. If we can see the zygosity score is closer to 0.5, 0.37, it's a heterozygous mutation. And I did not sequence any other members. It's still pending, so that was sent for sequencing, but I don't have the results yet. I was hoping that I will have it for at least for the brother.
Mm-hmm.
Just to clarify, in this case, the mutation is heterozygous, not homozygous, is not X chromosome. So in any case, they're going to be heterozygous for the mutation.
Yeah, I'm sorry, heterozygous. Mm-hmm.
What's the current treatment that the patient is on?
So right now he's just on fluconazole treatment because they're not really quiet now without any steroid treatment. Sorry, so right now, after he was discharged, the thing that he's mostly struggling with is oral thrush again, without any severe GI symptoms for now, so there is no rush to start him on some other inhibitor, the way I see it. And he's doing okay on 3 days a week of fluconazole.
Okay, so no immunosuppressive treatment at this point. Okay.
Not yet.
So what's going to be your concern of using JAK inhibitors in this guy? So I heard about the NF-κB story. I heard about offer paper, but keep in mind that that paper, they were patients with severe, long-lasting, non-responsive invasive fungal infections. So in any case, you can conclude for the same paper from offer paper is that JAK inhibitors didn't improve the patients and didn't correct the course of the infection. It's not that they developed the infections while they were in JAK inhibitors. They were very severely ill, and that was kind of a last resource attempt because failure for multiple years of treatment. So it's clear that JAK inhibitors, depending on what you think that you're treating, they might have a different outcome. So most of the papers that they showed that it worked, it was regarding CMC plus minus immune dysregulation manifestations, while when you are trying to treat and rescue unrescuable infections, there's where definitely they fail. So I think that you are into something, a good option, a good targeted therapeutic option in this guy. Not sure that the NF-κB1 mutation is damaging or is really part of the syndrome or the phenotype in this guy, but probably some functional testing might help you.
Yeah, I definitely need to complete that and from some functional tests regarding NF-κB1. And that's another thing about the NF-κB1. So data about the allele frequency comes from another study that was mostly focusing on IBD in Ashkenazi Jews. And the allele frequency of this mutation was actually higher in the IBD population compared to, was higher in the control group compared to in the healthy group compared to the patient with IBD. So it actually might have a protective effect, even though it seemed to be in a very sensitive position. And so yeah, I need to complete the functional assay of the NF-κB1 to understand what actually the effect of the NF-κB1 is.
And there's a question that says that if STAT1 gain of function explains the picture, would you consider bone marrow transplant?
I think that the overall data, maybe it's a bit tricky question. I think that the overall data regarding transplant in STAT1 gain of function is not very encouraging. I think Jan Lading just published a paper about 15 patients. I think it was last month. And the results are not very supportive. I guess I think if you try to define which patient do better on after transplant, these are the patients with more immune dysregulation symptoms and not infections. And I don't think that the patient is severe enough to justify a transplant now. And it was actually maybe mutation specific. I think it's a T2M385 did the best, and even with this mutation, I think the overall survival was 60%. And transplanting the patient before the age of 12 was also an advantage in metavirus survival. So I think the patient is not severe enough. I think it's a bit maybe older than I would like to do that, but not severe enough. I think that's enough to say that we don't want to go to transplant.
Mm-hmm.
So how often, David, do you? Oh, sorry, Elena. So David, how often do you think, or how often do you encounter patients that they have two potential genetic explanations to their phenotype? How often do you encounter that, and how often do you think it happens in PADs?
I think there's a better paper, the New England cases you get more than one pathogenic mutation. So I think 5% is the number that I'm familiar with.
Yeah. So it means that if we have seen 20 patients, probably one has two genetic diseases. So that's not minor.
No, it's not. And I think that if we'll keep looking, we'll find more of them. I don't know, maybe we'll see. I think as for the question of the single copy, for me, I think the NF-kappa B mutation or haploinsufficiency so should be heterozygous mutation. So NF-kappa B1, it's considered now the leading cause for, or at least the most common finding in CVAD. And I think the spectrum of the phenotype is actually changing. I think it was first described in CVAD patient by Bodo's group, and then there was another paper describing an EBV and lymphoproliferative disease associated driven by EBV infection, and the third one described 3 different phenotypes. One of them was again maybe Behçet-like syndrome. The other presentation was again CVAD dysregulation with maybe arthritis, some form of arthritis, and the third one was severe skin necrosis after surgical cut without evidence for infection or pathogens. So I think, as in every disease, we start with a single phenotype because we look at in a specific population, let's say in this case CVAD, and then you find it there. But if we'll ask the question differently, what does people with NF-kappa B1 mutation have, then we'll get a different picture. And as people will find it more, then we'll understand the complete phenotype of the disease.
Great. Any other questions, or this may be a good time to...
I think we should move to the next presentation.
To the good one. To the good one.
Yeah, to the better one.
It was a great case. Thank you, David. This was a great case.
So can we switch?
All right. So let's see if okay, yes. Sorry. So I'm going to talk about a case that I saw recently, about a little 6-year-old that I met. Is this going? Yes. So she was 6 when we were first consulted, which was just a couple of months ago. And she was a previously healthy child, born term, no hospitalizations or surgeries, and they had the first episode of ITP when she was about 2 years old. She got treated with steroids, had complete resolution, didn't think much of it. Then went by for another 3 years, and then at the age of 5, in 2016, had her second episode of ITP, was treated with steroids, and everything resolved again. Sorry. Then a year later, at the age of 6, in 2017, then she had her third episode, and then this one was harder to treat. In addition to steroids, she needed to get high-dose IVIG, which then still didn't improve things. So then they put her, basically every time they tried to wean the steroids, her platelet count would drop significantly. And they essentially kept her in a very, very long wean. So that kind of takes us to the middle of 2017, when she was about 6.5. So because they had a hard time getting her off of steroids, they added another immune modulatory treatment, and they started CellCept. They were able to keep her platelet count stable in the 100s with this, but every time that she would get a cold, she would have a dip in her platelet counts, and she would get petechiae, which is usually sort of the symptoms that parents notice. We met her in November of 2017 when immunology was first consulted, and hematology colleagues essentially started feeling that this was an unusual case of ITP, that it was fairly recalcitrant to treatment. And at that time, even while being on CellCept, she had another dip. When she has a dip, her platelets drops to below teens. It can go to single digits. And she got a steroid burst. They decided to double up on the CellCept, but still the platelets were less than 5. She was on the outpatient getting frequent visits in hematology clinic. And then in December of last year, they got her off completely on steroids and just on CellCept, and then she developed petechiae again, which is usually what the parents notice when her platelets drop below 5. She was started in Amicar, but then complaining about headache, vomiting, came to an emergency room, and then was found to have a subdural hemorrhage with midline shift on CT. While she was hospitalized, she got multiple platelet transfusions. She was also on high-dose steroids, and then she was started on sirolimus. And then it was during this hospitalization that we got to send multiple evaluation labs. I am sorry. Looking more into her past medical history, she is a child who has had short stature. So you can see her weight. She's not a big kid, but she's sort of able to at least be on the curve, while when it comes to her height, she's definitely not even sort of hitting the bottom of the 3rd percentile. And then she has prepared normal development, no really other major medical problems. Many had some atopic dermatitis that was easily treated topically. She got a whole vaccines and did well with them. She has a pretty benign infectious history, basically was treated with antibiotics once for an episode of acute otitis media. And she has not had history of any pneumonias, no other hospitalizations other than this one, no skin infections, no rashes, no joint swelling, no joint pains, no diarrhea, bloody stools, recurrent fevers. Her family history is interesting. The father has hypertension, hypothyroidism, and then has a sister who passed away at the age of 4 many years ago in 2004. She was also treated at our hospital, at Children's Hospital, Colorado. She was initially diagnosed with HSP, and presented with extremity edema, rash, and abdominal pain. She was 3 at the time. Within months of that diagnosis, which by my understanding, she was treated, and it seemed to improve. But a couple months after going home, she had seizures and then also developed renal failure. Renal biopsy was consistent with glomerulonephritis. And she met criteria for SLE diagnosis, although the rheumatologist felt that she was always an atypical form of SLE. and within a year of essentially her diagnosis with HSP initially, then she basically presented to the ED with candidal sepsis. She was very sick in the ICU, pancytopenic, ascites, pleural effusion, eventually passed away of ARDS. There is no other history in autoimmunity or immune deficiency. The question on the size of the platelets, the patient herself, her platelets were macrocytic. Sorry, not macrocytic. They were large, not small.
And was the sister treated with anti-immune suppression and immune suppression to explain the sepsis, the candida sepsis?
Yeah, that's a good question. It was a little hard for me to dig up much in the history for sister, mainly because she passed away in 2004.
Okay.
But from what I can tell in the notes, she was treated for her glomerulonephritis with immune suppression. And that's as far as I can tell. So I'm not sure if the candida sepsis was related to that. But I mean, I would say that for someone to have even candida basically from a blood culture, I don't know. I think we have to be very, very immunosuppressed for that to happen. And I don't think I saw that in her chart, but I'm not sure. Okay, any dysmorphism for the patient? She looks definitely short. I would not call her dysmorphic, and certainly not the features that you would see in Turner syndrome, not like web neck, that sort of type of look. So it was during this hospitalization where we were consulted, and we got some immune labs. This is similar to what David presented. So we got TB NK cell subsets, and they looked okay. So at this time when we evaluated her, so she had been basically, this is when she had her head bleed, and she was on high dose steroids, and she had been on Celset before. Her counts look overall okay. We also looked at her Tregs, and the percentage in the report looks okay. Sorry, I don't have flow plots for you. And we did that National Jewish. Then we sent out a T-cell immune phenotype, and we're essentially looking for any signs of T-cell activation. And things, I think, looked overall pretty okay as well. Nothing that was jumping out. I mean, you could say her CD4 and CD8 cells probably have a little bit more of HLA-DR positivity that you will want, but certainly nothing that was dramatically out of range, I would say.
I think maybe the CD8, you can see that.
Let's see.
I don't know, I'm not sure if it was the CD8, CD45RA, maybe a bit high, and I don't know if these are activated stemmer cells or truly naive.
Yeah. I would say a little bit, but I've definitely seen profiles where it's a lot more prominent also.
Yep.
And then we just checked complements, and those were normal. Her immunoglobulins, we checked twice during sort of her time, and those were the results in ranges. She has normal vaccine titers to tetanus and diphtheria. Because of sort of her ITP and her sister history of SLE, who was taken care of by the rheumatology team here in the hospital. Rheumatology was involved during this hospitalization, and there were several autoantibodies that were checked, and as you can see, everything is fairly negative. And I'll remind you that in the sister who eventually received a diagnosis of SLE, she actually did not really have an elevated ANA nor anti-double-stranded DNA when she first presented with the HSP pictures. It really was several months later when then those were checked again, and they were elevated, but they were also not dramatic from what I could see in the chart. Well, okay, should I pause here or should I?
Yeah, there's a question about antiplatelet antibodies. Do you know if that was checked?
Good question. I think for the patient, I think that was checked and that was positive. I'm pretty sure that was positive.
So, Elena, was the patient the failure to thrive postnatal, or did the patient also have intrauterine growth retardation?
The patient herself, she did not have intrauterine growth restriction. We asked about that, and mom
so everything was
described
postnatal.
that at the big, everything was postnatal.
Hey, Elena, is this a consanguineous family?
Yeah, well, it's funny you asked that. You know, I asked that in many polite possible ways, and they denied. But I have my suspicions that there is some consanguinity.
Mm-hmm.
Yeah. Ops-like phenotype. Did I check double negative T? Well, so she didn't have lymphadenopathy, and we did look for that on exam. So I did not end up checking for double negative T cells.
Okay, so maybe we should, if there are no other questions.
Okay. All right. So when we got involved with the family, we said, okay, you know, we want to look at some immunological parameters. And sort of hindsight 2020, I thought about sending intracellular, actually either plasma or intracellular cytokines. I will say that the fact that she was getting at least 2 mg per kilo IV twice a day of steroids, I think gave me some pause whether I wanted to send plasma cytokines or not. So anyway, we didn't end up doing that, but that's something that I wish I would have done. But we sort of talked with the family, and knowing the history of the sister and knowing this picture, we said we would like to proceed with genetic testing. So we sent a primary immunodeficiency panel that has 236 genes, I think, and we did it through Invitae, and we got a result back. Let me see here. The CD4 and CD8 is very close to CD3. Okay. Right. So this is what we got back from the genetic testing. So she is a homozygous for ACP5, which this is the very long name of the disease. And so I'm going to say SENS for short. And this is sort of the variant that you can see. It is predicted to be pathogenic, and on the exact database is found at 0.009%. She also has a variant of unknown significance, where she basically is a het for PRKDC, and then that's a missense mutation that you see there. And then on the exact database frequency is 0.09%. I don't have a CMA, but that is definitely a good thought. And I wanted to, so I have to say that when I got this report back, I honestly did not know very much about ACP5. So thankfully PubMed is very helpful. So I kind of wanted to show you some of what I learned, that ACP5 is one of the type 1 interferonopathies. And as you can see, this very nice review by Rodera and Crow basically summarizes the type 1 interferon pathway and all the different defined interferonopathies that we have to date. And ACP5 is there as an inhibitory protein. So if you're missing this, then essentially you will have induction of all with type 1 interferons and all the ISGs, the interferon-dependent genes downstream of that. So they are, when I started sort of looking at the different publications, so there's a couple of reports that actually, so when I started reading, it's actually confusing in the sense that I want to point you to here that The initial description was basically just spondyloenchondrodysplasia with the skeletal abnormalities, and then a couple of papers after that then describe the same skeletal abnormalities with immune dysregulation. And then the latest nice recapitulation series that was published in the Journal of Clinical Immunology, it has a recapitulation of the different publications to date on either the cases of skeletal abnormalities only or skeletal abnormalities plus immune dysregulation, and it shows you the different mutations and where they are in the gene, and I'll show you a picture about that. But as far as the skeletal abnormality goes, they tend to have skeletal dysplasia, and the paper describes as the skeletal survey to be quite key and helpful. That essentially they took patients that if they actually had a interference signature, that they had a negative skeletal survey, and then they sequenced for ACP5. None of those had an ACP5 mutation or hit, but that the ones with a skeletal survey did have ACP abnormalities, did have ACP5. And I know you're going to ask me if I have a skeletal abnormality for her, and like I said, I've only met her a couple of months ago. We just got these results very, very recently. I discussed this with the family probably three and a half weeks ago, and we decided that I thought it was a good idea for her to be evaluated for endocrine, to really look at the stature issue, and then for them to sort of take the role of the appropriate x-rays that should be taken for the skeletal survey. So I don't have that for you, but they are fairly characteristic, is my understanding from reading. You know, in terms of the severity of lesions, though, of the skeletal problems is really quite variable when you look at the list of their patients, and it also progresses. So some patients do not have them until later in life, and it's a slow progression, but definitely short stature is also fairly common to most of the patients. The neurological dysfunction, they can have some neurological delay and spasticity. She definitely does not have spasticity. I mean, the parents don't have any cognitive concerns, but I will say that as her physician, I may have some. So I'm also having her being evaluated by developmental peds. And then in terms of autoimmune manifestations, it's interesting to me, and the most common was autoimmune ITP. It was 46% of the patients. And then SLE was 36%, and it usually had the renal involvement. So I think, thinking now back about the sister, I think that could explain that, you know, when she had, quote, atypical SLE, you know, she probably is also a homozygous for this. And I'll tell you that we now, just like David mentioned, I don't have the sequencing for you on the parents. We're testing them for carrier status, and they agreed to be tested. It was just sent off recently. And then because the sister was a patient in our hospital, we do have biopsy samples, and we did extract DNA, and that's already sent and also pending. So we will know if that's the case for sister, but I'll say that I have a really high suspicion that that is probably what her sister had too. Let's see. Okay. The other autoimmune manifestations were less frequent, like vasculitis and scleroderma. Many of them had elevated serum interferon alpha, not surprisingly, and upregulation of interferon-dependent genes. And this is, I think, a nice picture that summarizes the different mutations that have been described. And our patient has a mutation that it's not actually been described, but it's fairly close to others than half. So I think I think we can assume that, and actually the prediction software that Invitae uses, essentially the report, they label it as pathogenic. Other questions? Okay. So that's, I think, kind of what I discussed with the family, and the current status is, she's with endocrine to really look at the skeletal survey and see. We're going to get a developmental evaluation. As far as her thrombocytopenia, she is off steroids and she was on sirolimus, and I put her on sirolimus before I knew the result of this genetic testing. And she's therapeutic, and her platelets were holding okay. It was sort of in the 100s, but she had been on the 300s when she was on high dose steroids. So I'm a little worried that it's not going to hold her for very long. And I think the scenario now is that with knowing that this can explain her picture, let's just say that her platelets hold okay on sirolimus. Would you still want to treat with JAK inhibition? And if she doesn't, by my eye, right, like she has short stature, developmentally, I think I have some concerns, but I definitely don't think she's terribly delayed. So if I started her on a JAK inhibitor, we think I can halt some of the natural progression that's going to happen in this slow progressing disease. I don't know. I'm looking for some thoughts.
Hey, Elena, did these kids, do they have brain MRI abnormalities like the Cartier-Gautier kids can sometimes?
Yeah, it's a great question. So I didn't include the pictures on the slideshow, which in retrospect maybe I should have. But I have the paper here from the Journal of Clinical Immunology, which basically has some examples of the skeletal abnormalities, and then it has some examples of head CTs. What they see is actually more like intracranial calcifications, but not so much like what the Cartier-Gautier kids have.
Mm-hmm. So,
and we did take a head CT for her. That's how she was found to have the midline shift. She does have some calcifications. And, one of the things that the hematology people commented is that they definitely have tons of ITP kids who drop platelets before 5, but they don't get head bleeds. And they thought that this was unusual for her, and whether that's related to potentially the abnormalities in the brain that you see in someone with this. And I don't think I can answer that. I think what I've learned about the brain sort of abnormalities is the intracranial calcifications, which I think in the paper they even say that it's unclear their significance for that.
mm-hmm.
Yeah.
Yeah.
Let's see. What else did I want to? So there's a comment here. Yeah, so I think she would be a great candidate for, so there's comments here about monoclonal antibodies for some of the type 1 interferon monoclonals. I think she'd be a great candidate for the interferon receptor monoclonal, afrinilumab, if I'm saying that correctly. But I really doubt that I would be able to get that even at compassionate use, because they're on trials right now, and specifically for SLE. The data looks really promising, and I think in general they don't want to essentially want to use it outside of their indication that they're being successful for at the time of trial. Rituximab, yeah, I think either rituximab. Yeah, that probably, I think I will worry a little bit about rituximab on a child this young. I don't know about the experience for you, but I've definitely seen a good number of kids and adults who don't recover their B cells well after rituximab. So there's a part of me that will be a little hesitant for that. Yeah.
Mm-hmm.
Would you have hesitation of JAK inhibition for her on a 6.5-year-old? And whether I can get it or not, I think is a challenge. I'm curious on your thoughts on that.
Yeah, I think it's reasonable to try. That seems like a logical intervention, and yeah, I think that would be reasonable. The hard part with that, of course, is how are you going to monitor? How are you going to monitor to know if it's doing anything for you or not, right? So,
right. So
I would check. I don't know if these children it's probably not reported, but do they have elevated CXCL10 or elevated CXCL9? I would take, or CXCL11. I'd take a look at the chemokines to see if there's any evidence, and it may take repeated sampling to see if there's any obvious, sort of appearance there. Or you could do gene expression just out of PBMC, right? Because the type 1 interferon signature is so strong in lupus patients and a lot of other interferonopathies, you might see it.
Yeah, no. So my question I had too is, I think we can definitely do that on a research site. What are sort of some good CLIA assays that I could do to monitor, quote, her interferonopathy? So I like the idea of the chemokines. For interferon signature, like gene expression, which I really like, my understanding is that they aren't really clinical assays. Those would be on the research side, which is fine, and we can do that. But is my understanding correct there?
Yeah, that's right. And I'm not sure of any CLIA CXCL10 or 11, which are probably more useful than the 9 that our lab will do.
Yeah. Okay. So I'll think about those things. And that's sort of the problem, that if I start the JAK inhibition before, she's truly thrombocytopenic, I'm not really sure, if I do it, if she fails sirolimus, then if we know that her platelets recover on JAK inhibition, then, well, I would know that it's working, I guess.
Mm-hmm.
Okay. I think I think insurance is going to be a challenge, but we will fight the good fight. Well, thank you guys for your comments and your attention. I think we're coming right on time. Is that right, David?
I think we have. Thank you, everyone, and whoever goes to the Quad AI, enjoy the meeting.
Thank you, guys. Great cases.
All right. Yeah, those are great cases. Thanks.
Thank you very much.
Thanks.
Good night.